Welcome, everyone. This is the Behavioral Health Echo. Thank you to all of you for being here today. Before we start, I want to remind you that this session is being recorded for later distribution. However, the information that you see on the chat will not appear on the recording. So we invite all of you to identify yourselves on the chat by adding there your names, email addresses, and affiliations. This information is very important for us to confirm your attendance to this class, especially if you're seeking CEs today or if you're part of our provider network here at Be Well, Texas. If you're joining by phone, please send us an email letting us know that you were here. There is no way for us to identify you just with your phone number. And as always, if you need captionings, you may navigate to the bottom part of your Zoom window and click on the captioning feature. During the second part of this session, we're going to be discussing a case. And as always, I have to remind all of us that we will discuss that case, always protecting the identity of the person we are discussing. These are very important PHI, personal health information compliance issues that we should always refer to and comment before we start discussing any case. So we thank you in advance for understanding and following these very important guidelines. And with that, we're going to move to our introductions. Dr. Antoine, how are you today? Welcome. Do you want to introduce yourself?
Thank you so much. Yes, Dr. Dennis Antoine, coming from Baltimore. I'm the director of the Addiction Treatment Services Program and Cornerstone Clinic programs there, and I'm a psychiatrist by training.
Thank you. Katie.
Hi, I'm Katie Dondedville. I'm a clinical psychologist. I work here at UT Health San Antonio, and I specialize in training mental health providers and treatments for trauma and trauma-related disorders.
Thank you. Didi.
Good morning from California. So we're still in the morning here. I'm Didi Stout. I'm a professor at St. Mary's College in Moraga, California, in the Graduate Department of Counseling and Forensic Psychology. I'm also the author of a book called Coming to Harm Reduction, Kicking and Screaming, working on the second edition right now. I'm a trainer in a few things. My expertise lies in motivational interviewing and in harm reduction psychotherapy, where I practice something called holistic harm reduction psychotherapy. And I have a private practice, consulting, training, work with individuals, couples with addiction, substance use disorders, other behaviors.
Thank you, Didi. Dr. Aguilar.
Hello, everybody. Happy Fiesta for those of you that are in San Antonio. My name is Clarissa Aguilar. I'm a licensed psychologist, and I'm a behavioral health consultant in our integrated primary care clinics inside our certified community behavioral health center, where we treat folks with chronic medical conditions, but also that are recovering from substance use disorders and co-occurring severe mental illness.
Thank you. And our case presenter, Kim, thank you for being here. You want to introduce yourself to the group?
Sorry, I'm a little challenged. I'm Kimberly Wilson. I work in the Council on Alcohol and Drug Abuse as a recovery coach. This is 1 year in the making, so this is a new career choice for me. So,
thank you. Thank you. So we can move to our presentation whenever you're ready, Dr. Aguilar. We are going to share your slides. Karen, if you have them ready.
Yes, thank you, everyone. While Karen gets my slides up, I just wanted to kind of say, for those of you that were able to join us last month, we were able to talk about cognitive behavioral therapy, and Dr. Dondonville did a wonderful job giving us an overview. I'm going to review that just a tiny bit. Today, I wanted to get into more concrete steps related to kind of concretizing some of the content that we reviewed last time. So I've kind of talked about it as, or titled it as, the importance of small steps in behavior change, putting CBT skills into action. So next slide, please. These are the disclosures, no disclosures for me. Next slide. These are our learning objectives. My hope is that you'll be able to come away with something that's very concrete, some tools for structuring change, strategies for tracking progress, strategies for problem solving, and then really looking at some key concepts that are related to incremental change while you're doing CBT or using CBT skills. And hopefully you'll be able to glean a few behavioral interventions throughout the presentation. Next slide, please. So as I stated earlier, Dr. Dondenville reviewed and gave us a nice overview of the thoughts, emotions, and behavior triangle, right? And talked with us about the cognitive model of CBT, a conceptualization. We're going to talk today a little bit more about the functional analysis and why that's such a key piece in this sort of work that you do with patients. We talked about cognitive distortions, of identifying problematic beliefs, and really focused on how to help patients challenge their thinking using good self-talk. And she gave us some really cool ABC sheets. I don't know if y'all checked out those YouTube videos. They're really nice, very instructive, super helpful. She also reviewed the Unstuck model for helping people think about their thinking, which was wonderful. So today, I'm not going to reference those particular things, but understanding that the way that we structure CBT is kind of relevant, whether you're reviewing cognitive issues or behavioral issues. So jumping right in, we'll go to the next slide, please. One of the things, the hallmarks of CBT is to structure the visit. So one tool that can be very helpful is setting an agenda and then dividing your time, however much time you have with the patient, using the 20-20-20 rule, which is 20 minutes for a check-in, kind of having that introduction, greeting the person, understanding how they're doing, and reviewing the practice or the assignment from last time, spending 20 minutes in the middle where you really are providing that output, where you are discussing and introducing a new skill, you're providing maybe some psychoeducation around that skill, providing a rationale for it. And then the last 20 is really when you're wrapping things up, trying to be very specific and concrete about the kind of goals you're going to set, the homework assignment, how specifically the patient can do the practice that you're assigning for the day. Now, I work in integrated primary care and I don't get the luxury of a full hour. So my 20-20-20 is 10-10-10. Actually, so I try to shorten that down a little bit, but we do follow this very familiar format of checking in, providing a new skill, and then setting it up for the exit. So this is always an important skill to do. Next slide, please. This next slide talks about the structure and the way that the flow would really work. And one of the thoughts I had, we're not going to have time to kind of go through what a typical session would look like from beginning to end, but you're going to see components of it today. And so I wanted to kind of have you think about that, that this is a really the way that you would format your hour with a patient, or if you have, I don't know, like 40 minutes, you would try to divide it up equally. Next slide, please. The thing that I love about CBT is that it's predictable. It creates that structure. And one of the recurrent themes you'll hear me talking about today is about process and content. So one of the nice things is that in CBT, you would create agenda and create structure, and it helps the patient understand and know what to expect in the visit. And as you continually meet with them and provide that for them, the idea is that hopefully that process of learning that through you is something that they can internalize. So you're providing the content of an agenda every day, and that process is helping them understand how to use that in their lives. And so hopefully they will understand, wow, this is really key. This is really an important thing for me to do, maybe with my day, maybe with my afternoon, maybe when I think about how to think about my life. Maybe I should try to be more structured. So it's one of those process and content things. And you're going to hear me refer to that as time goes on. So this is an example agenda. Okay, we're going to check in. I'm going to talk to you about a different skill. We're going to work on assignments and then do a little checkout. Usually there's some kind of evaluation of the session sometimes in CBT. And I decided to kind of use the framework of a coping with cravings for this particular presentation. And so if that was going to be the task today in our CBT session, these were the tasks I would want for us to get done today: to understand what cravings are, describing what cravings are, identifying triggers, avoiding cues, meaning the environmental cues, not avoiding emotions, but avoiding cues that cues, and then coping with cravings. Next slide, please. Principles of CBT. I don't know if y'all still see the same slide? Oh, here we go. I guess it maybe is a little bit of a lag on my part. Is that, again, these are some of these skills that kind of cut across sessions. Oh, hopefully you guys can hear me okay. These are some skills that cut across the session. So for example, many of the skills in CBT are generalizable, meaning that any of these skills can be applied to all sorts of problems. You kind of want to start with basic skills first and then build on skills as you go. The idea is also that the patients will practice the skills that you're learning through repetition and repeating not only the practice, but you might need to repeat the rationale or repeat the instruction of it. You also always want to match materials to a patient's needs, kind of using the language that would be understandable for them. You want folks to practice mastering skills. So the only way to master a skill, the way you might master, doing CBT, is through repetition and constant practice. So that's a really key emphasis of CBT work, is trying to make sure that patients are learning and practicing, ideally in session, but then, of course, having that practice outside of session as well. Sometimes people won't do practice if they don't understand why. That clear rationale can be very key, especially if you can link it to their own particular life circumstances. That's when CBT is most powerful, is when you are able to use everything that a patient gives you and blend in your particular skill exactly into their issue or their struggle. That's when it really becomes powerful. So if you're able to do that, that's wonderful. We also like to try to get commitments. Yes, does this feel like something you can do this outside of our session today? Yes, I can. That's ideally what you would want to hear, but we all know that doesn't always happen. You want to anticipate obstacles, monitor closely, always do that check-in about their homework, and using the information you have, the data that you have, to dig into how a patient is feeling about how they're doing. So on that note, let's go to the next slide. This functional analysis is a particular skill that is something that you do with the patient, trying to get an understanding of, can we go to the next slide? The trigger, the thoughts and feelings. This is a record of what is helpful for you to complete with the patient, specifically during that early check-in, and you ask them if there's been any instances where they might have used substances again. And if there is an instance, this is a great opportunity to use the functional analysis to get an understanding of what happened, what was happening before, what happened after, when they used, what were the outcomes of using cocaine, for example, and then what were some of the negative consequences related to that as well. So you're kind of guiding the patient through that. And the idea, hopefully, is that they will also understand and internalize how to use this particular this particular skill or this particular behavioral analysis on themselves as time goes on. So the functional analysis demonstrates understanding patterns of substance use by analyzing thoughts, feelings, and behaviors before and after an episode, right? But it also hopefully can make it clear that this patient can use a functional analysis towards any kind of problematic behavior going forward. So you might want to ask, what were you doing? Where were you? What happened before you were using? How were you feeling? How aware were you of wanting to use? What was the high like at the beginning? How did it evolve? How did it change? What was it like later? Can you think of anything positive that happened because you used? And acknowledging that, writing that down. And then what were some of the negative consequences of using? How did you feel at the end? And so these are practiced questions that hopefully the patient can understand how to use going forward. So again, this is one of those things where you are teaching them the skill, but you're also conducting it with them. Next slide, please. So this is kind of just a little bit of a summary of how the functional analysis is used in those first 20 minutes, because you might need to, you're checking in to see if they had any other substance use. So you might need to use a functional analysis to break down the behavior. You might also give the functional analysis as a homework. And it gives you some of these like insight into how the patient is seeing their own behavior and how well they are able to read their own behavior and some of their own triggers. One of the things here is that a functional analysis is an executive functioning skill, which is related to the way that we problem solve, the way that we make decisions. And there's been some recent neuroscience works that talked about this profile of addiction and how helping folks with problem solving, decision making, things like that fall into executive function can really help in their outcomes. So the functional analysis is just one of these kind of key skills and key concepts in CBT. Next slide, please. One of the other ways that's a very easy way to kind of track progress, which you might want to do during that initial check-in, is use one of your screeners. Dr. Dondenville had also reviewed a few months back screeners that you might be able to use, like the PHQ-9 or the GAD-7, and you might want to track that over time. Sometimes what I do, even if I don't have a PHQ-9 or GAD-7 with me, I might just ask simply, how are you feeling today? You know, with 9 being the best and 1 being the worst. And then just tracking that over time by hand. I know we would all like our EHRs to do it, but sometimes we don't have access to that. So next slide, please. You might see, you can just graph the scores. I'm a Gen X graduate school person, so we didn't really have EHRs that would track things. We did all this stuff by paper all the time. So it's not something that bothers me, but I know like our newer clinicians are always looking for the computerized versions of stuff. But this would be a simple and easy way just to keep track of things over time. Next slide, please. So again, kind of thinking about the coping with craving session that I described, these are some of the key elements that you would want to try to address in this session. We're not going to spend time on all of these, but I did want to talk about a few of these skills again, so that you all might be able to lift out some behavioral interventions that might be helpful when you are coping with craving. Next slide, please. So one of the things that is helpful is helping the patient really understand, and this is part of helping them understand their own psychological knowledge, their own psychological understanding of themselves and insight. And so sometimes folks actually are very psychologically minded, but haven't ever been asked these sorts of questions like, how long does it last? How bothered are you? So you're helping the patient get a very good understanding of themselves. And you're helping yourself get a lot of information about how to track things and what to look for, and help a patient set themselves up for protection against, further cravings. So these are some great questions that you might want to ask when you're thinking about describing a craving. Next slide. That's kind of one of the tasks that we had outlined in our agenda. And so then through that, you also get to learn about what the triggers are, you know, when they're talking about and describing their craving and talking about where they were and what it was like. And so you want to be able to help the patient start to recognize, okay, I notice that every time I go out and I'm on this street and I'm walking by this bar, this is what comes up for me. And so you want to help the patient avoid, and again, I want to be clear that I'm not saying to avoid emotions or avoid feelings, but to avoid the environment, avoid the cue that is going to trigger the craving or the want to use. And so avoiding these stimulus, avoiding the cues that the person has kind of been conditioned to over time is really key. I have also spent time, depending on the person in front of me, if I can explain Pavlov's dogs and the operant conditioning, if y'all have heard of Pavlov and his dogs and the way that the conditioning occurs with certain cues, I've gone into that whole story to help people understand that there is nothing wrong with them. There's nothing flawed about them. This is our biology and how we get cued by certain triggers once things have happened over and over and over again. So once they've been paired together. And so then, of course, if there is a need to cope with a craving, if a craving is triggered, then you want to learn how to cope. So next slide. That's when we really try to focus on some of these skills. And so these are some of the skills that were laid out in the session for how to cope with the craving. So distraction, talking about the craving, going with the craving, kind of riding that wave, thinking about all the negative consequences. And so one of the things that we're doing is thinking about distraction. That's kind of what we're going to focus on today. Next slide, please. So I always like to tell people, you know, make a list, write it down. Leaving the situation is also helpful. It's always more helpful if the distraction is physical, like going for a walk, doing push-ups. Next slide, please. You might see this particular slide kind of talks about all the different things. Like this is also a list of pleasant activities. If you can do double duty, it's something that a patient really enjoys. It might also be a great way to help a patient distract from the craving. Next slide, please. And so this is kind of something that I might hand to a patient and say, like, these are some reminders. Remember how to surf that urge wave as it comes up. I might have them complete a log. Go ahead and go to the next slide, please, where we talk about, this is an example of somebody that completed a cocaine craving log. And then I have a blank one on the next slide. It can kind of show you how somebody completed that. And the coping with craving is a really important tool and log to be able to complete in a session. And then if we go to our next slide, I'm going to skip this one and go to the next one. We're going to talk about problem solving, which is, again, that process and content-oriented skill. Oftentimes, when you're checking in about, okay, how are you going to use this? When are you going to try practicing some of your deep breathing that you might be using for coping? People will say like, oh, well, I couldn't do it because I got too stressed or I didn't remember. So I usually take them through the problem-solving steps. Again, this is one of those skills that you can do with the patient in the room, and it's a key skill for them to learn and take with them into their lives. And so using the problem-solving formula and outline is very, very important, and it's one of those skills that can serve them well as time goes on. So next slide, please. So this is kind of more information on the problem-solving process. And then if we go to the next slide, we're going to kind of, this is another executive function skill, so it's a really important key thing for them to take home with them. And go to the next slide. When you're wrapping up and trying to set a goal, you all have probably heard of SMART goals, right? To make them be specific, measurable, achievable. So you might say something like, okay, starting on Wednesday, I'm going to be practicing some deep breathing skills. And if I have my craving, I will walk outside and also breathe for 10 times and practice that every morning with my coffee. So that way, it's realistic, it's time-bound, and it's achievable. Next slide, please. Typically, what I also have our patients do is try to rate their ability or kind of their importance, readiness to do this activity and their confidence in doing this activity on a scale from 1 to 5. And I have a laminated sheet that I kind of bring into the session to say, okay, how important is it for you to try to do this? How ready are you to do this? And how confident are you to do this? And usually it really helps us figure out and problem solve if somebody's not feeling very confident, if they're not feeling very ready, how to help them move forward. We usually want everything to be over 3. I might rework it if it's under 3. We might kind of go back and try to figure out what we can tweak in our skill if that becomes, if it's not very important. And then we might have another discussion about it. Okay, so next slide. These are the references that I used. I kind of rushed there toward the end, but I wanted to make sure we had enough time. So hopefully you were able to glean some skills. Please let me know, next slide, if you have any questions or if you wanted more information about any of this information, specifically on the coping strategies or some of the CBT skills in a particular session on substance use. I'd be more than happy to answer. Thank you.
Thank you, Dr. Aguilar. Now we're going to open the floor for questions, comments. Sure that some of you also attended the last session. That was the first part of CBT, but you may have questions or comments. Okay. So if there are no, yes, Amy, please. You can unmute yourself. Thank you.
Yes, I have a question. I have 2, 3 particular participants who, for them, they're using is like breathing to them, trying to get certain distractions, trying to find them different coping skills, grounding techniques. I think I've gone over everything, and we still come back to the same where, you know, like it really hasn't changed very much. I don't really know what else, you know, how to go about it. I just keep talking with them, trying to help them get past those situations, trying to help them deal with anything that they're any traumas that were in the past. I'm just kind of at a loss, like where else can I go with that?
Yeah, it does sound like perhaps the folks that you're talking about are, well, are they ready for change? Do they talk about wanting something different for themselves right now?
Yes, because they are older and
Okay.
they realize, especially with everything going on with fentanyl, you know, they don't want to wind up in a situation that's going to hurt their families even more. And so they've come in willingly on their own to try and find a way to, you know, I've gone over harm reduction with them so that we can slow it down a little bit, try different forms of moderation, talking with them, and it works for a little bit, and then it goes back to that. And one of your forums on the analysis, I was like, oh, I was doing that with them. I was like, okay, I'm doing something right.
Yeah.
So I was like, okay, but we always wind up coming back to this thing because they've done it for years, and since they've been using since they were children, very early age in their youth, and now it's just like breathing to them, like they reach for a cup of coffee, and this is what they do too, according to their substance of choice. And it's very hard from, you know, it's been kind of hard trying to figure out what do I do next? How do I go about this?
Yeah, so one of the things I hope I said, but I may not have, was that in this process, and specifically if you're already doing this functional analysis, is I try to grab, specifically with somebody that is using a lot, is try to grab try to lift out from that functional analysis, like, oh, okay, so it sounded like you tried to delay there. Is that right? You were trying to like maybe get away from your family member that was bothering you before you used? Okay, tell me about that part of you. So trying to highlight that little piece, there might be something in that whole analysis that you're able to pull out, but you really have to like look at it. And then I always say like break it up into pieces and find that one piece that's a little nugget of goodness and highlight that. That's kind of one suggestion I have. I don't know, team, if you all would like to weigh in.
Yeah, I like to use the term, it's just an old lyric, don't run away from the darkness, but run toward the light. So sometimes people may not like to avoid the consequence. So it is really best to highlight what's been going well and really reinforce that in a positive way.
And
Thank
I'll
you,
jump
Dr.
in on the
Gonzalez.
same sort of bandwagon here and say one of the things that I love to ask people, and so they may say that, you know, I really screwed up last night. I wound up using, you know, oh my God, I didn't mean to do that. And so the next question can be, so tell me about the days you didn't use, or the moments in between. How did you not use? And that always surprises people because they think they're supposed to talk about the bad stuff, you know, just when I'm in trouble. And it takes them a moment, I have found over the years, to kind of shift that and go, oh, I haven't even ever thought of that before. Because nobody uses 24/7. Not possible. So looking for those glimmers of space between that can be, as both, you know, Clarissa and Dennis were saying, just that sort of glimmer of light of, oh, yeah, you're right. I don't use all the time. Let me focus on that for a minute.
Good, great, thank you.
And you're doing a lot right, by the way, Amy.
Yeah.
Thanks.
Thank you, Didi. Anyone else? Any comments or questions for Dr. Aguilar or the group? If not, let's move to announcements, but we may go back to this didactic presentation while we're discussing our case in the second part of this session. So Karen, if you can show us the announcements, please. Thank you. And remember, if you or your organization is dealing or is facing a difficult case, this forum here, this space is the ideal place for you to share your case. Of course, in an anonymous way, always protecting the identity of the person in question, but it's a great opportunity that CSTAT gives all participants, all providers, to discuss a case and get the feedback and insights from hub experts and other people in the community. So if you want to present a case with us, please send an email to the email address Karen is sharing right now in the chat. That is cstat@utesca.edu. Thank you. Next. And CSTAP, the Center for Substance Use Training and Telementoring, offers technical assistance. And what is technical assistance? Well, it could be clinical mentorship, cases consultation, linkages, or communication with additional resources or groups in the community. Anything that you might need in your own respective practices. If you want to complete a technical assistant form, what you have to do is go to our CSTAT website. There is a form there. Someone will get back to you somewhere between 2 and 3 days with an answer. Next. Next. And BWell Texas is still recruiting participants for a very interesting survey. This is a survey for all those who are enrolled in buprenorphine treatment, of course, over the age of 18 years old. There is compensation available for participating in this study. There's a long way to go. We're still looking for a lot of participants. So if you're interested, please call us or send us an email to the information that we're sharing on the slide. But actually, we have here from the research team, Dante. Dante, could you unmute yourself for a second and tell us a little bit more about the research, please? Thank you.
Hi, everybody. My name is Dante Sepulveda Allen. I'm a research area specialist with the research team here at Be Well, Texas. Thank you all for having me today, letting me speak a little bit about the study. For some more information, essentially what it is we are currently recruiting for a clinical trial that's testing the efficacy of a mobile app that will go hand in hand with buprenorphine treatment, medication-assisted treatment for opioid use disorder. This study is going to be 100% virtual. The participants will just be downloading the app to their smartphone, and they'll be making 2 visits a week with the study staff, and that will be over the phone or over Zoom. And that will be for the duration of 13 weeks. It's about 3 months. As well, we'll mail urine drug screening kits to the participants for every visit. So they'll be doing twice weekly urine testing. Compensation will be provided. Up to $270 is possible. It comes out to $10 per successful visit that they do, and we pay that out once a week. As far as who we're looking for individuals anywhere in Texas. They don't have to be, because it's virtual, they don't have to be in San Antonio where we are. They can be from anywhere in Texas, 18 and older, who have recently begun buprenorphine treatment to treat opioid use disorder. And then as well, they need to have a smartphone or a tablet that allows them to send and receive texts and emails. As well, if you all know of any patients or people that would be interested, we'll be sending out a flyer via email after the echo session, and they would just need to scan the QR code. That will take them to an interest form that we have set up. Once they fill out that interest form, we'll give them a call, and we can pre-screen them and see what exactly they're interested in and if they qualify. As well, I'm going to put here in the chat, we have a direct line for our research team. If you want, you can pass that number along to any people you think may be interested. And they can call that Monday to Friday, 8 to 5, and anyone on the research team will be able to answer and help out.
Thank you.
I
Thank you,
just want to
Dante.
quickly say, and we're running out of time. I was a part of the creation of the Kios app and all the content. It's really user-friendly. It's very personalized, and they did a really nice job of making it engaging. So it's really cool to see it being studied in this way. So I'd recommend it to clients.
Awesome. Thank you. Thank you, Katie. Well, so you have the information there, phone number and email address. If you know someone who wants to participate in this study. Next slide. And next month on May 21st, we have the 5th session of the webinar, Thriving in Substance Use Disorder Service Delivery in the Post-COVID Era. Dr. Garcini will be talking about mitigating grief and loss post-pandemic. If you want to register, just go to our CSTAT website and you can register there. Thank you. Next. And next month, we'll have Dr. Antoine discussing pharmacological approaches to substance use disorders. Again, you can go to our CSTAT page to register for this session and for all the other sessions of our ECHO programs. Thank you. All right, and Kim, whenever you're ready, we can start briefly discussing your case. Karen may share the form on the screen for you if you want to, or you can do it as well.
She can share.
Sure.
Okay. This is a 46-year-old male, heterosexual. He, on his profile, he states white, but also identifies as American Indian. My concerns about him is he has reoccurring incarcerations due to terroristic threats. He has a history of prison time for sex crimes, so he is a registered sex offender. So it's becoming increasingly difficult to find housing, jobs, or entry into inpatient facilities here, due to the history that he's had. He does have physical and verbal altercations. He has anger issues, no housing. So he keeps returning after he exits. He keeps returning to friends' houses and hops and ends up having a reoccurrence. Every time he gets out, what he wants, what his vision is to have a stable employment, housing that's, free of long-term housing, that's free of drugs, that's in a safe environment. As far as his existing strengths and resources, he does have a brother who supports him, but wants to maintain his own sobriety. So he's reluctant to keep on helping him and housing him whenever he re-enters, due to his trying to stay sober. MHID, he attends our mental health and intellectual disability center for mental health and medications. He does use the Nueces County Clinic card as well, to see doctors. He does have a phone and attends sessions with RSS here and there. I've been working with him for almost a year now. And obviously use motivational interviewing with him. I've assisted the, very first time we sat and did resumes together and sent them off. And I encouraged him to follow up with these people that he did turn resumes in for. I referred him to other organizations, like the MHID, the Coastal Compass is where we use for hiring. He always comes back with the excuse that they're not doing anything. I've transported him here and there and everywhere to make housing appointments. He does, when he's out, he does stay in touch with me. Like he schedules every week face to face and then calls me in between. So he stays in touch. I've sent him to Ozars for an assessment to get into our inpatient treatment here. And during the interview process with the facility, the sex charge came up, so they would not take him there. And then obviously positive reinforcements. He's gotten better and better from doing nothing to actually going out and getting work in between these last 2 stays. Getting work and getting housing. He did get housed in one of our shelters. But he's banned from RTA now, the regional transportation system. They're probably not going to let him into this facility because he has burnt the bridges with the other facilities for housing, for shelters. He has a history of stimulant use, methamphetamines. He does smoke, alcohol, and cannabis. Substance use counseling, he's not there yet. Inpatient substance use treatment, he has not had. Mutual aid, smart recovery, no. He has not taken any medications for his for any opioid use disorder or alcohol use disorder. He does have a history of depression, mania, anxiety, PTSD, and he has been diagnosed schizophrenia. Let's see what else. He is currently involved with the criminal justice system. He is now incarcerated for the second time this month for terroristic threats. Basically, people make him mad and he doesn't stand down. He is on the following medications for his mental health disorders: the bupropion, the hydroxyzine, and the, I can never say that, Q1 on the top. And again, the therapies are intervention, motivational interviewing. I don't know about the CBT or contingency management, harm reduction services, obviously, and then the peer recovery support services, which he is active with me whenever he is out. And none of the others that I know of. So my problem is what do I do with him? Because that call is going to be coming soon. It's been about 5 weeks, he's going to get back out and he will contact me as to what to try next. I'm pretty much used every resource that I have here.
Thank you, Kim. Okay, so
And
we're opening the floor then. Yes, Dr. Antoine.
I was going to say up front, Kim, you've done a really, really great job working with him so far. I just want to put that out there. Clearly, there's a history that leads to some barriers for him, and I think you working with him takes a lot of effort on your part. So, big kudos for that. A couple of things I'm curious about with the medications, and then I'll open it up for questions for others, of course. Is he getting those while he's currently incarcerated, or is that what he was on before he went in?
I'm going to have to say he's not getting them in, because when I get him on the way out, we start the process all over again with MHID.
Okay, that's helpful, and I'll speak to that a little bit later. And I'll pause there just to let other folks ask questions.
Just a clarifying question about the MHID. Just want to make sure, is that the local mental health authority?
Yes, ma'am.
Okay,
It's
so
mental health. Sorry, go ahead.
It's the local center where he's getting his medications, but any other services there? Like, is there housing supports inside that, a housing program that he could use or access?
They're associated with pathways. So I'm glad you brought that up, because that might be something that I can check into when he gets out this time. I think that's the last resource that I have. As long as he's on his medications and stuff, they will take him in there. So that might be an idea. I'm not sure what their guidelines are as far as his background.
So on that note, our particular, where I work is our county facility as well. And we have therapeutic justice programs that he would fit. I don't know a lot about Wessex County, but you might want to ask if there are any, like we have here in San Antonio, mental health court and what they call drug court, that helps folks route them through to treatment if necessary. But I don't know a lot about the infrastructure in Wessex County, but it's something to ask. If nothing else.
Thank you, ma'am.
I see a question in the chat that I'll bring into the conversation here. Has he had any counseling for his own trauma? I'm assuming from the check boxes that the answer might be no, but wanted to double check based off the question.
Right. No. It's just a miracle that I've got him from where he was to even contemplating going into a treatment facility. Like, he was, I don't need help, I don't have a problem, to, yes, finally he's contemplating he wants to go in. And so we took steps toward that. So he hasn't had counseling, he hasn't any inpatient or outpatient treatment. So we're just like right at the edge right there, but I don't want to lose him when he comes out this time, because we've gotten so many rejections.
Understood. And I'll just kind of get into it a little bit further. I mean, it seems like, one, if you can get any records from his incarceration as to what they did there, that would be helpful. Typically, persons that are medicated while they're incarcerated have a clearer picture. And that way you might not have to start over. So getting a running start on that while he's there with the release of information would be good. But, going to Dr. Aguilar's presentation, I'm really curious about what are the typical ABCs of his behavior. Sometimes we say, what does his functional analysis look like as to when he relapses? Because it sounds like this is a cycle, and to be able to anticipate what the settings and the sequence might be, and whether he recognizes his emotional state or the place where he is when that uses, and let's not go there this time.
Right.
Let's not go to that store, go to that corner. That might be a good place to look at. And you're already doing the reinforcement there. But I'm struck by the fact that he just keeps showing up to you, but he doesn't go to a lot of other stuff. So well, and you could just ask him, hey, why do you like coming to me? But are there other people that we can connect you with to enhance that support. It may not be 12 steps, may not be NA, but there might be a tribe for him to connect with, that could amplify his support and be a different type of place or people, to enhance what you're doing, not to get rid of him at all, but
Right.
you clearly have made a good connection with him, and you just want to see him have more of that. That's probably the best way to frame it. Again, going towards the light, not away from the darkness on that.
Thank you.
Yeah.
And by the way, Kim, there are also harm reduction groups online that he can connect with that are all over the country now. We're doing more and more of them through an organization called Harm Reduction Works.
Okay.
Now it's on Zoom. You access it through Facebook. I do hear he's got a phone and he could do it that way. You know, obviously he can be completely anonymous, but it's sort of support for any goal. So if he's uncomfortable with that, talk about abstinence or any of that, and just wants a place where he can talk about his goals or
Okay.
what's getting in his way, that might be something that he could access.
Thank you.
Yeah.
And I would say the big part of this, and I know we're close to getting to wrap up here. There is a lot that is put on paper that seems to be a barrier, and I do wonder whether he sees it as an issue that these bridges are being burnt, because we see it as an issue. But just because a person has consequences doesn't mean it's necessarily something that they're driven by. So it'd be good to get a sense of what drives him, going to that functional analysis of behavior, going
Yeah.
to why does he show up to you, using that together to say, all right, I want that future for you as well. But right now, the future looks like there's less options. How can we create a future driven by what he wants to
Right.
get more options? And that seems to be a way of looking at it. Most of us would say, hey, if you keep doing this, you'll lose everything. And he may not be consequent avoidant, as we always say. So
Right.
that seems to be a strategy to tell him that you want to build that future with him, and maybe there's a way to get something that will build that rather than focusing on the things that won't get him there.
Yes, thank you. I'm glad the functional analysis came up in there because I figured if he sees it in writing, black and white, in those boxes spread out like that, that might, trigger him to think of something different, We're almost to the point where I think my contact at our local MHID may have a place for him, possibly if I can get him back into there, but in another city.
Yep. Yeah, no, it's definitely, he would benefit from the counseling and the therapy,
Yes.
for sure. That's a huge portion of it. Just to clarify, what is he dealing with?
Yeah.
Not just a diagnosis, but life story wise. So, again, you're taking the best steps to get him there.
Thank you.
And Dr. Aguilar says here, the fact that he returns to you each time, Kim, and he comes out in is such a testament to the relationship, reliability, and connection that you have established with him. And this is great work.
Thank you.
So I think in the interest of time, maybe do we have any more questions from our learners, from the community of learners? Anyone who has managed a similar case in their organization and wants to add something or suggest something before we go to our summary? Okay, Pastor Deb.
Just quickly, we do have some complicated folks like that, and I have found one thing that does help them is belonging to the local club, the AA club, the 24-hour club. If they feel that they're going to use, they can go there. And some of our ones that are doing well here volunteer there and take a shift. So I just wanted to say, I didn't hear that, but we're community based, so we're not professionals like y'all. I just wanted to share that anecdotally, that the local Lyerly AA club has been a tremendous support, 40 years in action. Thank you.
Oh, thank you. Of course. Okay, so in the interest of time, Dr. Antoine, would you like to give us quick summary of the session and some
Absolutely.
recommendations for the case. Thank you.
Absolutely. So I think the summary, in my mind, focuses around what Dr. Aguilar presented on and how to really get clarity on what's going on with the individual from a functional level. And the case really highlighted that with an individual who has a complex history socially with legal issues, also incarceration that's ongoing with some charges that might be barriers for him and also some difficulty engaging in services, except for with Kim, who has really been a big support. And now the work becomes how to get clarity for him as he's coming out of the system. And I think the functional analysis is an excellent place to start. In addition to increasing his resources that are available, but finding a place for him where he's driven to go towards. And that includes people who are professionals and aren't professionals, as Pastor Deb pointed out. But as long as they're supportive and positive for his recovery, that's the biggest thing. And so I think that's going to be a combination of you being there for him, but finding more things for him to do that will put him in that direction. And I think it will also include clarity on what are the best medications for him and the best counseling services, because he needs that support to break the cycle and get a different ABCs on that functional analysis.
Dee Dee, did you want to share what you are discussing in the chat?
Yeah, I was just putting in the information for Harm Reduction Works meetings. It's coming from Harm Reduction Works 413. A couple of buddies of mine on the East Coast. I was just there doing a keynote for their conference in New Hampshire and got a chance to actually speak with them and meet with one of them I've never met. I love how that works out. The other one I've known for about 30 years. And again, abstinence is a part of harm reduction. Please do not think otherwise. So people who want abstinence are welcome there. Anyone is welcome there, any goal. And it's just a terrific group. They have also expanded into friends and family groups. So looking for
Great.
non-traditional ways for friends and families to support their loved ones who are using drugs or perhaps using chaotically.
And I love hearing that, Dee Dee, that phrase abstinence is a part of harm reduction. That's
Absolutely.
very inclusive, and I like that.
Yeah, thanks, because it is.
Great. All right. Well, thank you to all of you. This has been a good session. As always, remember to answer that post-session survey that we will be sending right after the session, and give it approximately 2 to 3 weeks for you to receive your certificates via email. Thank you again for attending the session, and we'll see you next month. Thank you all.